Hi, everyone. Welcome to Rare New England's annual conference, Learning from Each Other. Um, Today, we're going to be speaking about rare resources in New England. My name is Nicole White. I'm the Executive Director of Rare New England. And again, we thank you all for being a part of this conference here today. First, I'd like to thank our sponsors for making this, for helping us to make this happen. Ultragenyx, first I'll list our platinum sponsors: Ultragenyx, Horizon, and Vertex. Our gold level sponsors, Grail, and our silver level sponsor is Homology Medicines and Stealth Biotherapeutics. I'll hand it over to our moderator today, Kevin.
Thank you, Nicole. Welcome, everybody. I'm really excited to listen to this panel today. The webinars we've done in the past couple of weeks have been sort of topical and deep. This one's going to be a little more practical. Where can people find help for their taking care of their own rare disease, learning how to work through the system, or doing it for their children or whoever they're taking care of? The structure of today's panel, we're going to hear from Nicole again, and she's going to tell us her story, go a little bit deeper in it. And I want you to take that as sort of a backdrop to what you hear from our next three speakers. We're going to hear from Chuck Bergamo, who's going to give us some thoughts on financial planning, navigating system, some of the other things that he's involved in. He'll introduce himself. We're going to hear from a couple of people from Project Access, Giselle McDonald and Lauren Kelly. And then you're going to get to hear from me again, and I'm going to talk about my company that I do when I'm not volunteering for Rare New England. But before we get started, let's get a word from our sponsor. Go ahead, Elizabeth.
Hi, everyone. My name is Elizabeth Maya, and I work in patient advocacy at Ultragenyx Pharmaceuticals, and we are honored to be supporting Rare New England's wonderful virtual conference. I am only 3 weeks into my role here at Ultragenyx, but I was asked to share a little bit about the company and what I've observed so far in the past few weeks. So just to give you a quick background for anyone who is unfamiliar with Ultragenyx, the company was founded in 2010 by our president and CEO, Emil Kakkis. And Emil is a physician and a scientist who dedicated his life and career to understanding the needs of the rare disease community and bringing treatments to people who need them most. I've had the chance to speak with Emil a few times over the last few weeks since joining, and I will say that he is also one of the most humble and approachable people that you'll ever meet. His passion for his work really comes through in all of his conversations, and it's just been a real pleasure to get to know him. Since founding Ultragenyx, Emil and his team have really focused on rare diseases in the ultra-rare communities, where there is clear biology to target, but where there also aren't existing treatments in the space. So to give you a little understanding, 4 out of our approved therapies, 3 of them are the only approved therapies in their respective diseases. And out of the 18 diseases that we are studying, 17 of those currently do not have existing therapies that address the underlying disease in the majority of patients. So we're really working in a challenging space, but one that I feel offers so much reward for everybody involved. I personally had the pleasure of going out to California last week, where Ultragenyx is based, and getting to spend some time with the company and the team. And I really found it so rewarding that there is such a commitment, everyone involved in Ultragenyx, to the rare disease community, not just the communities that we're working in, but really across the board in the rare disease space. There's this deep dedication to helping patients obtain early and accurate diagnosis through genetic testing programs, and really to openly sharing our science to help advance future scientific development, which I think is really often rare to find in this field. What I love too, especially in my role of patient advocacy, is the dedication to the patient and caregiver community. Everyone at Ultragenyx is committed to understanding the unique needs of each community that we're working in, and really engaging in two-way conversation and partnerships to help further our shared goals of creating mutually beneficial therapies. So for example, we hold a Rare Entrepreneurs Boot Camp annually to help individuals who are raising money for research understand the drug development process. And annually we hold an ultra rare family day, which was last week, where we're joined by members of the rare disease community across all rare communities to really get an understanding of what it's like to be living with those conditions and what we can be doing collectively to help those. So there's really some great work happening thanks to people like you who are willing to share your insights and experiences with us. I personally have spent the last decade working in the pharmaceutical industry across many rare diseases. I'm also a New England girl who has been living with a rare autoimmune liver condition for the past 25 years. So I'm really excited and honored to be working at a company that truly puts the patients and the caregivers at the center of what we do. Even more so, I am thrilled to be partnering with and especially learning from all of you who are involved in Rare New England. So on behalf of Ultragenyx, just thank you so much for all that you do to engage and help us in our work.
Thank you, Elizabeth. It's great to see the commitment from a company that really feels this, that has been there for many years, working in the rare community and has become part of the community. I think that's what we need more of. So, Nicole, why don't you tell us your story to get us started?
Sure. My story started 10 years ago, or I should say 11 years ago, when I became pregnant with my son. I was a first-time mom, and when my son was, when I was 12 weeks pregnant, I went for my regular ultrasound, and they had told me that our son had a rare birth defect called gastroschisis. So his intestines and other organs were developing on the outside of his body. Of course, you know, as soon as you hear that, I think when anyone is told that they are being faced with a rare, you know, either birth defect or a rare condition, the first thing you do is look for resources and support. And unfortunately, you know, when you are in that position and you're faced with those challenges, the first thing you do is go to Google. Because you're not living in that world, so you go there. Luckily, I was able to find some support there, but through different organizations that specialized in his condition. Fast forward to April 2012, I had our son Kyrie. It was one of the best times in my life and one of the most scariest times. 6 days after he was born, surgeons removed the majority of his small intestine, leaving him with a condition called short bowel syndrome, which is also a rare disease. He is dependent on IV nutrition and a feeding tube to survive. I'll never forget being in the NICU with him and just saying, you know, I just want my son to live. I want him to be alive and here with us. Every new parent or every parent's wish is to have a happy and healthy baby. So, you know, we were faced with many challenges right from the beginning, including one specifically where, you know, we were told that our son wouldn't see 2 years old. So that being said, we were advised by social work to get him on Social Security. So I was, you know, 2 weeks postpartum. My son's in the NICU, and I'm by myself at the Social Security office trying to apply him for disability. I was alone. I didn't know what I was doing, who I needed to speak with. So I appreciate everyone, you know, taking a few minutes to hear my story. You know, just as Kevin had said, like a backdrop to today's talk, the importance of resources and in the rare disease community. You know, we all need to come together, and you know, I appreciate our speakers here today to provide and you know, speak about their organizations and who they work with and the populations that they support, because it's so important. I will add to everyone, if you have a resource that you are available, that you have access to, or that you came across and you felt that really helped you, please share with us. We're always looking to grow our resource lists so we can better help the community together.
Thank you, Nicole. And you reminded me that I need to tell people that they can put questions in the Q&A form. I don't think the chat is functional, but we'll be able to send you some messages through chat. If you have any questions or you want to make a comment, you can do it through the Q&A, and we will monitor that as we go along. And we're going to start out with Chuck Bergamo, who's got a very interesting story and has gotten himself into several different parts of the rare disease community.
All right, thank you, Kevin. Thank you for having me. I kind of wear a couple of different hats, as I explained to Kevin and the other panelists when we had our pre-session. First, I'll start with similar to Nicole. I'm a parent of a child with a genetic rare disease, SYNGAP1. So that is kind of what, in a very long-about way, brings me here today, from being involved with that community and it being a rare disease, only discovered in or about 2015, I want to say, and only from pure happenstance did we find out about my daughter having it, because we were doing pharmacogenetic testing to control her epilepsy, and although the testing turned up a big zero as to what pharmaceuticals would work, it did disclose her SYNGAP1, which just gave us the name for why she has epilepsy, intellectual disability, etc. So with that, I've become very involved in the disability community here in Connecticut. So one of the hats I wear is I am a chairperson of the Connecticut Department of Developmental Services Western Regional Advisory Council. Well, if you're in the state of Connecticut and you have an intellectual disability, which means your IQ is under 70, then by statute, the Department of Developmental Services is the entity which you go to for services. And potentially you get a budget, group home, in-home care, Medicaid waivers, etc. And so that was one of the reasons I got involved, was so I could educate myself on all this. Even though I'm an attorney by background, a financial planner, etc. When you start working in this area or dealing with your loved one in this area, it can be very confusing. And so as sitting on that panel, I get to hear a lot about what Connecticut Department of Developmental Services is doing, what the issues are. The big issue now, where a number of years ago, the big issue was financing, that is money, during the days of Governor Malloy, and there were threats for cuts, etc. Now the big issue is finding people to care for your loved one. There's a dearth of caregivers out there. And so finding placement for somebody, especially if they have behavioral issues, is one of the big issues that DDS is now dealing with. So I wear that hat. In addition, I sit on, these are all volunteer positions, by the way. I sit on the Connecticut Council for Developmental Disabilities. So if you're not in Connecticut, your state has a Council on Developmental Disabilities, which by federal statute deals with disabilities that arose prior to age 22 and are expected to last a lifetime. And they actually get money. Now, they don't get money to give to individuals for care or for services, but we give out grants. So for example, Project Access New Haven, who you'll hear from, they could apply for a grant to the Connecticut Council, and they would look at our 5-year plan and they would say, hey, we fit into this particular subsection of your 5-year plan, and we'd like you to fund us to build this project to hopefully build infrastructure and sustainability for people with disabilities. So one of our many, we have 9 goals this year. One of them deals with technology. So we're funding a lot with ARC, Mid-State ARC here in Connecticut. They do a lot in the technology space to show demonstration projects, and especially for caregivers, what's available by way of technology to help improve the quality of life of the person that you're taking care of. Because a lot of the states will follow what they call the life course program. It's all about what's the quality of life for the person with a disability. I also sit as the chairperson of my daughter's SYNGAP1 Research Foundation. So that's the rare disease. I didn't start it. Monica Weldon, who Kevin met at NORD, which I believe is the National Organization for Rare Disease. She was there this week. They're having conferences. She started it at the, as the story goes, kitchen table. Now we have, we do fundraising. And the purpose of that organization is to bring awareness and advocacy to the population that have the genetic mutation SYNGAP1. Most, I want to say, a lot of rare diseases have an organization, and that's a resource for information. So we see ourselves as a resource for information. The other thing we see ourselves as is kind of like putting our, the old nose of the camel under the tent. The pharmaceutical industry is a big industry. Government's a big industry. You got to push your nose in there and say, hey, look at us, pay attention. We have things we do. And so we have a, lack of a better term, a scientific conference that'll be coming up in 2023 to keep the scientists and hopefully organizations like the sponsors here interested in our rare disease, and hopefully they do research and study, because we all want a cure for our kids, or we can improve the life. Then the final thing I do, amongst other things, is I decided to get into, since I'm dealing with my daughter, I'm dealing with all these organizations and getting into the area of the people with disabilities. I found there's a dearth of good information out there for financial planning. So I do a lot of financial planning for families that deal with disabilities. And that's, once again, another, I don't want to say black hole, but I know as a parent of a child with a disability, there's no pause button. One doesn't have the ability to stop and just take their sweet time finding all this information out. So how do you find out information about SSI, SSDI, special needs trusts? While I'm dealing with taking your daughter to the doctor to change her medication for the epilepsy, while you're dealing with an IEP and a PPT, and then you're trying to figure out which dentist will take Medicaid or a Husky waiver. And then, oh, did I fill out the SSI application correctly? What about Medicaid? Somebody just gave my daughter money. What's an ABLE account? So you can get my point. So that's the other area. There are financial planners who specialize in this. I have a chartered special needs counselor designation. And I like to think I don't really do financial planning for those families. I like to think that what we do is quality of life planning. Because no matter what, it's really about quality of life. What's the quality of life you want for yourself, right? What's the quality of life you want for your child? And I hijack that, I'll be very upfront about it, from the life course materials that the state of Connecticut uses, which is really, it asks everything but, how much money do you have? But it asks all the other important questions. What are your goals? Where do you want to live? Who's going to change your light bulb when you're older? That may sound bizarre, but that's sort of not a question in there, but a question developed by the MIT Age Lab, believe it or not. But that gets you thinking about, when I'm older, who's going to climb the ladder to switch the light bulbs out? Where are you going to live? What's, etc. So that's what I do. I put my information in the chat. That is the links to the Connecticut Council on Developmental Disabilities. Feel free to visit that. If you're already getting services from DDS, you're familiar with them. And then I also, if you had questions for me, I gave you my contact information. And so I now turn it back to Kevin, our moderator.
Thank you, Chuck. That was great. There was a question that came through that I think we can answer now. We've got a couple minutes here. Is there a central source, state by state, for the types of services that Connecticut supplies?
You mean a sort of a clearinghouse? I'll go use an analogy. There's the National ABLE Resource Center. That's sort of a clearinghouse on ABLE accounts for all the states. Is there a clearinghouse that has every state and all the services state by state? I am not aware of such a clearinghouse. However, for those who can afford it, there are companies, by the way, that will do an analysis for your child. And let's say you want to move. So You decide you're gonna move, but you want to go to a state that's friendly for your particular child's disability. They will do an analysis and they will tell you where to go. They will give you suggestions as to where to move. I want to say, don't hold me to this, I want to say Pennsylvania is sort of an automatic enrollment Medicaid state. Like if you're over the age, you go there and you move and you become a resident, you automatically enrolled in Medicaid if you meet the criteria. Other states have waiting lists. Like in Connecticut, for example, if you don't have an intellectual disability and you have a diagnosis of autism, well, your services are not through the Department of Developmental Services, they're through the Department of Social Services, or DSS, and there's a long waiting list on the autism waiver. Whereas other states don't break it down by IQ, they break it down more by functionality. And I have clients in New York, the child has a diagnosis of autism, and they're getting services from the state because they don't have that statutory issue.
Thank you. So let's move on to the Project New Haven description.
Thank you so much, Kevin. And thank you, Nicole, for getting us started with your story, and Chuck as well. You know, Nicole, I heard you talk about resources and connections and help. So I'm very hopeful that as we share about Project Access New Haven, will be a resource for some of you that are listening, and also we'll share about the patient navigation model and the community health workers that do a lot of that work of making connections and help in the community. So I am gonna be co-presenting with Lauren Kelly, and what I'll do is share my slides so it can help us with the conversation. Just bear with me 1 second. Can everyone see the screen?
Yes, we can.
Perfect. Thank you so much. So who are we? Who is Project Access New Haven? So a little background on who we are and what services we provide to the community. Project Access, let me start. I'm going to multitask, so I apologize. Project Access New Haven is a 501c3, so we're a local nonprofit organization that was founded in 2009 by local providers who wanted to address the gaps in access to care in the area. It all started with a community needs assessment done with the support of RWJ scholars, Robert Wood Johnson scholars. And what they found at that time was a growing number of uninsured in low income and minority communities. They also found poor access to timely medical care for those without insurance, especially when it came to timely access to specialty care. So barriers to timely medical care disproportionately impacted underserved populations. The consequence of what they found were a very long wait time for appointments, a high no-show rate, and also a high number of emergency department visits and an overall poor health outcomes. So our founders created Project Access with the mission of increasing access to medical care and services for underserved patients in the greater New Haven area, with the vision of being the community champion for access to medical care for those that are most in need. Some key elements of our model, which we'll share more about today, is that we follow the volunteer provider network model that was developed in 1996 in Asheville, North Carolina, which has since then been replicated in over 100 communities across the United States. In New Haven, we have participating physicians who donate their time from Yale Medicine, Northeast Medical Group, and private practices, and Yale New Haven Hospital, who donates all ancillary and hospital-based services to uninsured patients enrolled in our program. And I also would like to mention that we have a very unique and very special partnership with Yale New Haven Hospital, which we're all Yale New Haven Hospital employees, but we're leased to the nonprofit Project Access. I do want to highlight today that we are local to New Haven. We serve all 13 towns in the greater New Haven area. So as I share the background, I do want to also share that in the last 12 years, we have expanded our patient navigation model, which is the core service at Project Access. And we now also have community health worker services. The team of patient navigators work closely with each patient to coordinate medical care. Our services are designed to guide patients through the healthcare system. As we hear the stories today, you can understand how complex they are. So what we do is include everything from scheduling and reminder patients of appointment. We call each patient before and after every single appointment. We coordinate services to address barriers to care. For example, we schedule transportation, we provide translation services, and ensuring that comprehension of that medical care plan. So explaining what the next steps are in the plan of care. As I shared, we're very local to New Haven. We currently serve uninsured patients in the greater New Haven area. Patients do have to be over 18 years old. They have to be uninsured or uninsurable, have a household income of less than 250% federal poverty level, and they have to have an urgent specialty care need. We average around 350 enrolled patients monthly in our uninsured specialty care program. And to date, we have coordinated over $74 million of donated care for over 3,500 patients. So as our patient navigators navigate clinical care, we now also have community health workers who connect patients with resources in the community to address health-related social needs, also known as social determinants of health needs. This can include anything from housing need, food insecurity, transportation, legal assistance, as well as filling out applications, as we heard from the stories today. So I'm going to explain a little bit more on the patient navigation model. As I mentioned earlier, we follow the volunteer provider network model. And what is unique, very unique to Project Access New Haven is that we also follow the patient navigation model based on Dr. Howard Freeman's patient navigation model. All of our programs follow the same navigation model, which is designed to promote a meaningful connection with patients and staff. Each patient that is referred to us to the program meets with a bilingual patient navigator to complete an intake. That intake could take anything from 45 minutes to an hour. The screening helps us when we do that intake one-on-one. It helps us build the relationship as well as understand and help each individual on their barriers to care specific to each patient. And we develop what we call an access plan to address those barriers, as well as we provide emotional support throughout their enrollment. So from the beginning, we always knew that patients didn't just have clinical needs, as we heard from the stories before, right? But most of our patients also have complex social determinants of health needs. So with help of our new grants and opportunities, what we have done is now have a team of community health workers that help connect patients with resources closest to them to help address their needs. And as I mentioned, they can be anything from food, housing, utilities, including access to a phone, internet, employment, legal assistance, financial assistance, medical equipment, and medication needs, just to name a few. So next, I'm going to pass it on to my colleague, Lauren Kelly.
Hi, everyone. So Giselle did already mention that the Project Access model that was developed back in 1996 in North Carolina included a key feature known as what we call our volunteer provider network. And essentially, this is just a network of healthcare providers and community partners that agree to provide free medical care and services to our patients. Now, when Project Access started back in 2009, we approached 2 local hospitals. At the time, it was Yale New Haven Hospital and the Hospital of St. Raphael, and a wide range of independent practices throughout the community, and asked if they'd be willing to participate. And many, if not all, were very, very willing to help to provide care for the underserved. The healthcare landscape in New Haven looks a little different today. Yale New Haven Hospital acquired the Hospital of St. Raphael, and now it's 2 campuses. And many of those practices do currently fall under Yale Medicine, Northeast Medical Group, some of those sort of umbrella groups. But we do still have a number of independent practices that agree to see our patients for free in order to sort of help and care for those in need in the community. And so when patients come to Project Access, if they have an approved referral for a medical need, all of the care that they receive that we're navigating through our program is provided for free. And in addition, we work with some community partners, including a local taxi company that provides free transportation to medical appointments. We've had some labs that have donated services. Equip Rehab is through Quinnipiac University. So if we have a need, we go out in the community and we ask for for our partners to contribute, and we have found them very willing in general to do that. Go to the next slide, Giselle. And one of my roles at the organization is to look at how we collect data and how we measure the impact of the service on those that we serve. So one of the things that we are always hoping for is that by providing the navigation services, that we are also helping to improve health-related quality of life for our patients. And so one of the ways that we do that is we do surveys when a patient comes at their intake visit, and then we do some follow-ups to about a year or so after they're enrolled. And we do see that there is an improvement in this measure called, it's the Healthy Days measure to the CDC, but it's a couple quick questions. And as you can see, the blue bars are at intake and red is at the follow-up survey. And so, we ask patients things like, in the last 30 days, how many of those days was your physical health not good? Your mental health, and then that third set is actually a combination of the two. And then the final one on the right is how many days in the last 30 days did poor health prevent you from doing your usual activities, things like taking care of yourself, recreation, work. And so we definitely see that there's improvement in that measure. And then if you can just go to the last one. And then another big piece of what our staff do is to try to remove barriers. So we know that there are a lot of things that could potentially get in the way of someone's ability to be able to prioritize their health, to get to their healthcare appointments, to understand and take advantage of the treatment and services that are offered. So one of the things that we do is really just barrier reduction, trying to identify things that could get in the way and then help those patients to remove those barriers. And so we ask about a number of things. As you can see, financial concerns, that is a big one. Also finding for our populations often, an insurance concern, finding providers who will be able to take them. And then sometimes it's communicating with providers, understanding the medical information and recommendations that are given, getting appointments soon enough, and things like transportation and filling prescriptions as well. So as you can see, follow-up, those are reduced. And we do see a pretty large number of increase in the percent of patients who say that when they're getting care through our program, that they actually have no barriers, which is awesome. And that's what we hope to achieve, that they're able to get to that appointment or able to get the care that they need in a timely fashion. And I think you can just go to the last one, Giselle. And I don't know if we can answer questions now or later, but we always would love for everyone to follow us on social media. There's more information on our website. And then feel free, of course, to reach out to Giselle or to me with any questions, call our office. We are always available to provide information and help them. Thank you.
Thank you. We'll pass it on to you, Kevin.
Great. Nicole, do you see any questions specifically for them?
Right now, no.
Okay, we'll wait till we get to the end.
Oh,
And we'll do Q&A.
I apologize. I do see a couple questions. If you'd like to continue, Kevin, and we can get to the questions later. Okay.
Yes. Sorry, folks, there's a little delay, and we're dealing with that.
Mhm.
So my name is Kevin Fryer, and I own a company called Salem Oaks. I started at Pfizer back in 1987. I spent 30 years there doing research and development. When I left Pfizer, finished my career there, I decided to start my own company. But let me introduce myself as a Rare New England person first. I'm the vice president of Rare New England. I'm on the board of directors. I've been on the board for a couple of years now and worked with the board and with the staff to build a strategic plan and get us moving in new directions. And so I really enjoyed it, and I'm happy to be here. Now I'm going to put my other hat on, and it's kind of odd sort of introducing myself so late in the whole presentation here. But as I said earlier, I spent 30 years at Pfizer in research and development. And during that time, I developed a broad and deep knowledge of how medicines are found and developed. And I actually spent a lot of my time there helping people within R&D, within Pfizer R&D, understand how Pfizer R&D worked. And when I got to the end of my career, I had a couple of things happen. I said, you know what? I should do this for people outside the organization, and go talk to patients, go talk to caregivers, go talk to the foundations that represent the diseases. And so I'm going to show you a short video here, if I make this work correctly. And it kind of highlights the problem that I saw needed fixing. Now, a little preface to this, the video was made for a health tech conference a couple months ago. And so the original video is really for those people, the innovators, you know, the health tech companies, the biotech companies, the pharma companies, the data companies that are getting involved. So I'd like you to take a couple minutes just to look at this, and then we'll talk it through.
Kevin, I apologize. We can't see the video.
Hang on a sec. You can't see the video. Could you see my slides?
No.
Oh. Let me take it back then. I think I know what I did. Just a second. So the point of our video is that, or the point of our company actually, is that the future of medicine is designed with you. When I say you, I mean, I'm talking about patients, families, caregivers. We need to involve you in the discovery and the development of new therapies going forward and in new innovations going forward. Everybody talks about being patient-centric, but there's a couple problems. And that was the problem that I saw. One is, well, there's a number of barriers to these partnerships between industry, innovators, and patients. The first one is language. Industry tends to talk in technical jargon and lots of scientific terminology, where patients and families talk about lived experience, what it feels like to have this disease or to have to manage this disease. Industry may not know how to talk to patients or talk with them, you know, actually have a conversation. It's new to them. And on the other side of it, patients may not know how or where or who to get involved with. How do you actually introduce yourself into this process? On the industry side, they've got compliance constraints. There are certain things they can't say because they would break the rules and the regulations of promoting something that's not yet a drug or not yet a product, a device. And sometimes you try to explain that, but it actually just makes the last thing for patients that I have noted here even worse. That makes it more intimidating. And people don't feel certain or confident about entering into these conversations, especially when they're talking to people around the table who have multiple advanced degrees. So this was the problem that we saw, and we decided to go out and find ways to address it. So what we really do is we help the patient see inside the box that Floof was struggling with. One of the ways we do this is through storytelling. And we help patients, families, caregivers, foundations use their stories and tell them with more impact so they can have more influence. Recently, we developed a storytelling workshop with the Barth Syndrome Foundation. We've entered their family events there, and we've started to talk to them, and we give them a chance to practice their stories. And by the end of the workshop, the students or the participants are able to deliver a compelling 3-minute version of their story, stimulate questions and answer them very concisely and understandably, and use that story to foster longer, more ongoing conversations. And actually, if they're ever asked to speak somewhere, they've already got the basics to tell their story and use it as the center of their presentations. The other ways we use stories are on the podcasts that we produce. I've got 3 podcasts. The first one was called Improbable Developments, or is called Improbable Developments, where we talk to scientists and people involved in research and development, and we let them tell their human stories. Who are they? We're trying to kind of, reduce the scariness of those white coats and say, these are just people and they're doing their job and they're very passionate about it. The second one we have is Raising Rare, and this is our biggest focus. It's a story of a father whose son is one of 9 in the world with his specific mutation and disorder. And we started talking when his son was 1 year old, and he just celebrated his 4th birthday. We've done 50 different episodes so far, and we're about to drop a few more. And we're just following their story about raising a child with rare disease, with a rare disease, and with the issues that come with that. We've expanded it now where we brought other families in, and we're just following that theme of what does it take to raise a kid when you're in this situation. And the last one we have is actually for community building. We're partnering with a pharmaceutical company. They're supporting us, and we're working with the Lambert-Eaton myasthenic syndrome community. We're just talking to people who have LEMS. And the thing about LEMS is it's not a childhood disease. It's something that comes on usually in your 50s and 60s is when it's diagnosed. And those people aren't as sort of enthusiastic about getting online and forming communities. So we're giving them an outlet to tell their stories, a place for them to hear about other people that have the same condition, and hopefully start making connections. We also kind of bridge the gap here between industry and patients. And because I've got my experience, so long in industry, and now I've got my experience, for 5 years now out in the world of patients, and particularly in rare disease, I can talk to companies and help them see the value of early patient input. Sure, it's easy to say, we should talk to you early and often, but really seeing the value and the business side of it takes some skill to put that together. We also help them understand the impact of having informed patients to speak with. Sometimes you just want to talk to somebody who's got a condition and you just want their raw sort of reaction. But sometimes you want to partner with somebody who kind of knows what's going on. And so we try to help companies see how important it is to prepare those people to come into something like a patient advisory board and help them understand the process deeply so that they can be a little bit more equal players at the table. We help them see how having those informed patients come in will help them better meet patients' needs and how it will enrich research with the lived experience. What's the experience? What does it take to participate in a clinical trial? With many rare disease clinical trials, people have to travel a long way. And sometimes they have siblings that need to be taken care of, or they have to deal with, leaving work for a couple of days in order to participate in these clinical trials. So you can improve the research and enrich it if you pull in the lived experience. So we foster partnerships between patients and industry. That's what we like to do. We do it through education, through the bridging I talked about. We work on behalf of both of them to get them working together. We stand in that place in the middle. We do some consulting work, and we've got some advocacy efforts. We've been very much involved in the RDLA's Rare Disease Day on Capitol Hill, organizing people in Connecticut in particular. So how can we help you? Well, you can go check out some of our programs that we've done. We've got some e-learning that's available. You can just go in and listen to it. We can also work with you to customize educational programs for what you need. We'll listen to you and figure out what we can bring to you or tap into somebody else who has the knowledge that you need to help you solve the problems you have. And as you saw with the storytelling, we do workshops to help you think through things, to help you structure your discussions. We work on building community through our podcasts and connecting with patient organizations. We spend a lot of time out there. That's how I got involved in Rare New England. And we do consulting. So I do strategic planning, communications, and can bring some expert advice to the table. And if you'd like to check out our e-learning, there's a link, or you could have used that QR code, or for those of you who caught it, or contact us through this link here. Now I have to put my Rare New England hat back on, and we're going to have a discussion. Let me just stop sharing here so that we can have discussion. So we have some questions that have come through. Hang on, I'm having trouble pulling them up. So I have one that goes all the way back to Nicole. It says, where did you specifically go for Social Security access? And this is from, actually, Robert Britting's been posting a lot of questions. He's from diseasehq.com, and he actually wants to add some information to it. So where did you go, Nicole?
At that time, being in the situation that I was in, unfortunately, I had the social work department at the hospital. They guided me, of course, to Social Security, and just like so many, my son was denied at first, and then we did have to seek legal assistance. But I do know if you can go to your, as Chuck had mentioned, your local disability, your state-specific disability council.
Yeah, if I can just say, for Social Security, the question is it SSI, which is Social Security Supplemental Income, or is it SSDI, which is Social Security Disability Income? And so SSI is an eligibility program. That is, you need to be poor to qualify. SSDI is an entitlement program, and so you're entitled to it because of either you have a work record and then get a disability, or you're claiming on someone else's record. For example, for my daughter, prior to age 18, even though she was disabled and Social Security made that determination, there would be no benefits for her because my parental income is deemed to her. So she doesn't qualify. At age 18, she becomes an adult here in the United States. And they say, okay, are you disabled? Check. Yes, she's disabled. Do you work? No, you can't work. You then get SSI. So she went on SSI, which automatically entitled her to Medicaid. Then, when I started collecting my Social Security benefit, I had to start collecting while I'm alive. If I died or was disabled, she'd be entitled to a benefit. But while living, once I started collecting my Social Security benefit, she then could apply for a family for an SSDI benefit. So she lost the SSI benefit and instead went on Social Security disability income, which was a bigger payment for her, by the way. And because it's an entitlement, there are less rules and regulations about what you can spend it on because she's entitled to it. Versus SSI, well, that's eligibility. You got to follow the rules of the program, what you can spend it on, resources, et cetera, et cetera. There are a number of things. So as Nicole pointed out, there are attorneys that will deal in that space. Also, anybody can help you apply, by the way, for Social Security. You don't need to have an attorney apply for you. And as she does point out, oftentimes you may get denied on the first round, and that's where you have to kind of get legal counsel involved. So I'm always going to tell somebody, start off with legal counsel if you're not sure. Certain conditions, I want to say there's something called a red book, a blue book, POMS. Social Security is very complicated. There are certain conditions that are listed as, I don't want to say use the word presumptive, but if you have ALS, for example, there was the ALS Act, which expedited results on getting Social Security disability. So if you have Alzheimer's, you don't have to jump through hoops. But the one thing that is critical is if you have a child is keep your medical records. Keep your medical records. And because that's where they're going to look. If you wait and wait and wait and you're 40 years and you're applying for a 40-year-old with a disability and you never asked for a disability, they're going to say, well, did it occur prior to age 22? All right, now you got to go get those medical records. So keep your medical records to document the disability.
Thanks, Chuck. We have another question. I don't know who can best answer this one, but what do you suggest as far as preparations for someone with a rare disease whose health is relatively stable right now? They can work, they have an income, but it's not quite sure if they're going to be able to do that later.
Well, my analogy would be by the way, in the disability world, one of the great challenges are people with mental health issues. If you have somebody who has, like, for example, Down syndrome, or like my daughter has SYNGAP1, it's an intellectual disability. It's pretty clear cut. Now, people with Down syndrome work, but my daughter's never going to be able to work. So we got to put a financial plan in place. We got to set up trusts. We got to start talking about housing. Once again, who's going to change her light bulbs, right? What's her social network going to be like when her siblings and family are gone? Who's going to get her an ice cream cone, as they say? Once again, all from MIT Age Lab there. But if you're able to work, so I'll have parents come to me and their child suffers from a mental health issue, and sometimes they're fully functional, working, making an income, and then suddenly can't work. Then suddenly can work, then can't work. So kind of like, what do we do? Well, you sit down, and once again, I go back to what the Department of Developmental Services uses in Connecticut and many states use, and that's the life course. Well, what's the quality of life that you would like for yourself or for your loved one? Well, how do we best plan for that? Well, it might be a combination of financial planning and then getting the right services in place that you can qualify for, so that when that time comes when you can't work, you're not going to be denied services because you can't work, because of income, and you've protected what you've built up. So that's a team of people. It's going to be an attorney. It's probably going to be a financial planner. There might be a trust company involved. But you start asking those questions. What's the quality of life and how do I best take the risks out of the system that can, the things that go bump in the night, as they say.
Thank you. We are just out of time now, and I think Nicole is going to close us out. We will get to the other questions. We will send you offline answers. Thank you for asking them.
Yes, I want to thank everyone for joining us today. I appreciate our speakers, Giselle, Lauren, and Chuck. We appreciate you so much, and we thank you for being a part of our discussion here today for our conference. I just again wanted to thank our sponsors, Ultragenyx, Horizon, Vertex, Grail, Homology Medicines, and Stealth Biotherapeutics for helping us make this possible today. So thank you again, everyone, and we hope to see you next week. And we will be sending out a survey as well. So if you can complete that, that would be appreciated as well.
Thank you.
Thank you.
Thank you all.
Bye,
Thank you for
everyone.
having us.
Yes, thanks so much. Bye-bye.